Well, hi, everybody. I got 40 minutes to cover a lot of shenanigans, so let's go. My name is Hadija Steen Mills, and I use they and she pronouns. You are in breakout room 2, talking about healthcare reparations and embodied approach to anti-oppressive public health. If you're not here and need to dip out, or not meant to be here and need to leave, that's totally fine. So today, our learning objectives, you're going to get an understanding of the basics of healthcare reparations approaches. What does that mean? A practical application of community-informed responses, specifically in the context of the COVID-19 pandemic. And you're going to have an introductory understanding of terms like intersectionality, systemic barriers, and Black feminist approaches, amongst other things. Lastly, the thing that's not on here is that time permitting, you'll have opportunities to connect and really get to start to move some synergy points forward. So the flow of today, we're going to do some grounding. We're going to do some storytelling. We're going to review some theories. We're going to talk about some recommendations for public health. And then again, time permitting, we're going to hang out and actually do some action items. I want to make a note that this presentation today is we are going to talk about COVID-19. We are going to also talk about death specifically related to COVID-19. We will also be talking about systemic racism and police violence. So before we begin, I really want to take a pause. We today are going to be, need to move you over. I really want to start with the grounding, and I really also want to acknowledge the barriers that exist for my and our Native siblings due to structural racism, colonialism, and white supremacy. So even though we are in this virtual space, I really want to personally acknowledge the land that I currently sit upon, what is commonly called Minnesota. It's located on traditional ancestral lands and contemporary lands of Indigenous people. And I work personally and reside on Dakota land ceded in the treaties of 1837 and 1851. I also want to acknowledge that I'm here humbly speaking on behalf of communities disproportionately impacted by the COVID-19 pandemic. If we were to put that in numbers from the APM research labs, that would be 1 in 390 Indigenous Americans, 1 in 555 Black Americans, 1 in 565 Pacific Islander Americans, 1 in 665 White Americans, 1 in 680 Latino Americans, and 1 in 1,040 Asian Americans who have died at the mercy of the coronavirus. Today, we're going to be going on a journey, and I really want to invite you to partake in whatever feels safe for you at this time. I really encourage you to find your points of synergy in this story. If you're an advocate, if you're an ally, if you're a change maker, a general badass, I really want us to work together to create radical systemic change. This work.
Uh-oh, did Hadija get moved out as well?
I just got kicked off.
Hey, I vanished.
Yes, we all did a little bit.
Okay, cool. Well, welcome back. Let me do some screen sharing again.
Thank you all for your patience with the ups and downs of Zoom.
Zoom live. All right. Again, are we good? Are we back? Great, cool. So as we continue our grounding, let's keep in mind that this work is constant and this work is embodied, and also this work is really, really necessary. And I want to start by grounding us in a passage from Archive by Alexis Pauline Gumbs, if anyone is familiar with that work. This is from Archive, the Archive of Sky. So after it happened, it was hard to remember how we walked on this land and breathed this air before without the thickness of knowing. They had always been here, every Indigenous community massacred, every single prophet assassinated, every child sacrificed to colonialism, every slave rebel shackled in their grave, every unassigned body piled as refuse somewhere. It had never disappeared. Whatever part they burned into air, whatever part they buried underground, whatever part they threw in the sea came whole again, in every breathing, growing thing. And when the warning time came, they were all of them screaming. And as we ground, I want us to keep that in context, that we are in a pivotal point right now, and all of us are screaming, and we have opportunities, and I hope that we can act on some of those things today. So again, I invite you to take a moment to feel whatever connection point you have to the ground, and keep in mind that that ground is holding you. Keep in mind that that ground has held you and will continue to hold you. And keep in mind that that ground is also holding everybody here in this virtual space as well, and that we are all connected. So let's go on a journey. 2020. That was a year. It was a year of possibility. It was a year of anxiety and unprecedented shifts in what's deemed normal. It also was a year of oppressions laid bare. It introduced a lot of Minnesotans to the systemic oppression that many more Minnesotans have known and experienced since the founding of this country. Still, we are existing in the crux of multiple pandemics that are now on display for a lot of new set of observers. There's the unjust acts of violence enacted on BIPOC communities by police. There's the lethargic response to the COVID-19 pandemic, and there's the lack of systemic approaches to addressing racism, amongst many other connected points. All of these things are on broadcast. So if we rewind back to May 25th of 2020, that was the day that George Floyd was murdered. To date, that is 11 months and 4 days ago. A lot has happened in 11 months and 4 days. The Twin Cities and the world came together to display their hurt, their rage, and their sadness. And a few weeks later, in the wake of the social uprising, the Minnesota Department of Health issued a statement strongly encouraging anyone involved in protests, vigils, neighborhood events to be tested for COVID-19. At that time, 4 free testing sites were really quickly erected across the Twin Cities. There were 3 in Minneapolis and 1 in St. Paul, and they ran for 6 days. It became clear that those free testing locations were actually not fully accessible for the communities intended for those services, and that set a precedent for the COVID-19 testing landscape. So I began to hear about the experiences of Black, queer, deaf, houseless individuals, the experiences that they were having in their attempts to get tested. Individuals who represented communities already reeling from the pandemic, police violence, and years of systemic oppression. These barriers included things like drive-up testing. Not everyone has a car. There were insurance requirements, mistrust of medical system. People were being charged for tests. People were being misgendered and dead named, and there were a lack of interpreters. If folks aren't familiar with the terms of misgendering and dead name, that is when somebody's name that they're assigned with at birth is used instead of their given name. Misgendering would be using the wrong gender for a person. It seemed obvious at that time that the barriers would really be impeding already under-resourced communities to get tested. And the world at that time was really looking to the Twin Cities for leadership into new futures. And the Twin Cities had a global duty to fight for equity. So there was a glaring opportunity for improvement and transformation. So I took that opportunity, and at this point, I haven't really looked back, and designed free walk-up, no insurance needed gendered training interpreter. I tried to address as many of those barriers as I possibly could. And also in addressing all of those barriers, I tried to take a little bit further and make sure that the communities who were being harmed weren't going to be harmed anymore. So how did I get there? The pandemic crowned everyone with new hats, and I suddenly found myself regaled in the jewels of emergency preparedness. I took a really deep dive at the time into the Health and Human Services Healthcare Emergency Preparedness Information Gateway, and I created what is now considered a typical testing map. This is at Phelps Park. If anybody is familiar with the Twin Cities, this is the park that is a block away from the George Floyd Memorial on George Floyd Square. So at this point in time, I was working with the objective of creating an accessible COVID-19 testing site, but I really needed to go beyond and further than what can be seen here. Under-resourced communities were dying at unprecedented rates. So what came next? So I'm a sex educator by trade, shout out to all the sex educators. And I was familiar with approaches to mitigate harm. Trauma-informed approaches are woven into all of my work. And it really created a solid grounding for humility. So to quote the Substance Abuse and Mental Health Services Administration, a trauma-informed program realizes the widespread impact of trauma and understands the potential paths to recovery. It recognizes the signs and symptoms of trauma in clients, families, staff, and others involved with the system. And it responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. There are 6 key tenets if folks aren't familiar. The first is safety. The second is trustworthiness and transparency. The third is peer support. Fourth is collaboration, mutuality. Fifth is empowerment, voices, and choices. Sixth is cultural, historical, and gender issues. And so I wove all 6 of these tenets into every aspect of a testing site. And then I had moved into a deeper objective, and that was to create an accessible and trauma-informed COVID-19 testing site. But how do we go even further? How to address the other barriers that we were hearing about, the historical harms committed by traditional medical systems, how to address the barriers rooted in systemic racism, how to be accountable and in conversation. So at this point, I layered on 2 more pieces. The first was creating positions, and then finding funding and hiring what I called community guides. And I think there actually might be a community guide on this call right now. Community guides are actually modeled after birthing doulas, and they're a support for the person who's being tested. They're a navigator for complex systems, and they're a barrier between the person being tested and the traditional medical systems. They're individuals who represent the communities that are disproportionately impacted by COVID-19, and because of the grant funding that I received, they're paid well. Here we can see in a blue vest, a community guide. So the second thing was embedding accountability into the bones of the testing approach, and that was a community-informed approach. So the testing site was designed to actively acknowledge the harms done by traditional medical systems and work against repeating those harms. The site was designed with humility at the forefront, and it welcomed continued learning and strived to compensate for that education. The site was designed with continued feedback and critique from queer, trans, Black, Indigenous, people of color communities, deaf community, and Twin Cities residents. And at this point, the objective was now clear. It was to create an accessible and trauma-informed COVID-19 testing site that acknowledged historical medical abuses that have hurt BIPOC and LGBTQ communities, a site that strived for inclusive cultural humility and did not further add to the hurt those disproportionately affected by COVID-19 were already experiencing. So here, we did it. In our first 2 days of testing, we tested about 400 people in 2 afternoons next to the George Floyd Memorial. And it was hot, like disgusting, Minnesota, humid, yuck. And doing that in PPP is just extra yuck. So here on the left, we can see a community guide with a COVID comfort care kit that was designed by the Million Artists movement. It had information and resources in an interactive format for COVID-19. Also in that fun little animal print bag, there were a mask that a person could take with them. We also partnered with different clinics because we needed the medical personnel at the time. It was the NP tests. So we needed those providers to do those tests. And here we partnered with the Community University Healthcare Clinic medical staff, COOP Clinic. And we made this accessible for folks. So actually my mom was able to come down. So shout out to Mom Rose. She lives near George Floyd Square and does not drive, and was able to toddle her little 75-year-old booty down and get tested for COVID-19, which was an awesome experience to see her support in that regard. So we had this opportunity to make change and build trust. And here we are with vaccines, but that's not the landscape that we're in. The cycle is again continuing. Here we can see the announcements from the FDA for the J&J, the Pfizer, and the Moderna vaccines. So this is continuing. And at this point in time, we're now working on comprehensively overhauling the youth homelessness response to COVID-19 vaccines, using these approaches to be able to hold and honor young folks who are at the intersections of these multiple pandemics. So what are the different pieces that were put into this whole experience? Let's first start talking about health disparity. So the CDC defines a health disparity as a preventable difference in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. We are existing at a disparity turning point potential. But what that actually means is that we are existing at an equity turning point potential. The disparity is the result of the inequity, and they really shouldn't be conflated. And that is one thing that I keep hearing is how do we mitigate these disparities? How do we change these disparities? But when actually what we're talking about is how do we make the world more equity-based? So how do you apply this into your work? How do you start with equity and move forward? We're gonna touch on a few different frameworks to ground and then get into some practice. Before we keep going with these different frameworks, I want to pause for a breath because that was a lot of information. It was also like a big journey back in time and into a space that is really hard to go back to. And I want to just honor everyone here and give everyone a little bit of breath and reprieve. I also want to acknowledge that I did not see the ASL interpreter, and I am really, really sorry that I was speaking so fast. So thanks for keeping up, and I'm really sorry about that. At this point in time, does anyone have any questions about that approach before we keep going and talk about the other good bits?
There was one question, Hadija, about getting resources about a trauma-informed approach. I shared with that person that source document from SAMHSA, but I thought I would share that question with you in case you had other specific trauma-informed resources.
Yeah, that document from SAMHSA is great. It's a really great starting point. I'm trying to see the question itself.
Oh, it was sent to me.
Oh, perfect. So the SAMHSA is a really great resource in terms of an overview of a trauma-informed approach. It is initially intended for substance abuse programs, but it's been applied in so many other areas. There's also some really great documentation. I have some of it in my resources at the end of the presentation about how it's been applied in sex ed and sexuality fields. And I think that's a really great example of how you can cross over this approach into many other different areas. Awesome. Cool. Well, then let's keep going. So the other thing to note is how do we internalize this into our core? Because this work is hard. This work is oppressive. This work is also, like I said at the beginning, so needed. And how do you embody the culture that is change? How do you embody the culture that is liberation? And that's really where we're coming from when we talk about all of these approaches, is that we're really trying to work towards a more liberatory future. So let's watch a short video. It is, I believe, about 2 minutes long, about intersectionality. It's something that folks have probably heard of a lot, but it's also something that can get really co-opted and misused. So let's start there. I want to make sure that my captions are on and that you all can hear it. Were you all able to hear that boop? Yes. Okay.
I was, yeah.
Perfect.
What is intersectionality? Intersectionality is a way of understanding social relations by examining intersecting forms of discrimination. This means acknowledging that social systems are complicated and that many forms of oppression, like racism, sexism, and ageism, might be present and active at the same time in a person's life. Everyday approaches to building equality tend to focus on one type of discrimination, for instance sexism, and then work to address only that specific concern. But while the career of a young, white and able-bodied woman might improve with gender equality protections, an older, black, disabled lesbian may continue to be hampered by racism, ageism, ableism and homophobia in the workplace. Intersectionality is about understanding and addressing all potential roadblocks to an individual or group's well-being. But it's not as simple as just adding up oppressions and addressing each one individually. Racism, sexism and ableism exist on their own, but when combined, they compound and transform the experience of oppression. Intersectionality acknowledges that unique oppressions exist, but is also dedicated to understanding how they change in combination. The roots of intersectionality lie within the Black feminist movement, with legal scholar Kimberly Crenshaw originating the term. Crenshaw felt that anti-racist and feminist movements were both overlooking the unique challenges faced by Black women. She stated that legislation about race is framed to protect Black men, and legislation about sexism is understood to protect white women. So simply combining racism and sexism together does not therefore protect Black women. Intersectional theory is now applied across a range of social divisions and also to understandings of domination, such as those associated with whiteness, masculinity, and heterosexuality. Intersectionality is not only about multiple identities, and it's not a simple answer to solving problems around equality and diversity. It is, however, an essential framework as we truly engage with issues around privilege and power and work to bring them into the open. Intersectionality means listening to others, examining our own privileges, and asking questions about who may be excluded or adversely affected by our work. As importantly, it means taking measurable action to invite, include, and centre the voices and work of marginalised individuals.
All right. So that video does a really, really concise and great job of talking about a really complex thing and really boiling it down. And shout out to Kimberly Crenshaw. If you haven't read any of her work, you should. And let's not forget things that were designed and created by Black women and not co-opt those things. So intersectionality is something that is really, really important in all of the work that I do. And I know many of the things that you all do as well. This artwork was created by a couple of folks for Audre Lorde Week from the Tulane University Office for Gender and Sexual Diversity. And Audre Lorde sums it up really nicely, is that there's no such thing as a single issue struggle because we do not live single issue lives. The other thing to highlight is a Black feminist approach. And the Combahee River Collective put it to a great point in 1977, and that if Black women were free, it would mean that everyone else would have to be free, since our freedom would necessitate the destruction of all systems of oppression. And this applies to all sub-marginalized identities. If the most oppressed are free, then so is everyone else. So intersectionality, Black feminism are some of the key tenets in healthcare reparations. So what does that mean? What is this term that I'm just like pulling out of my tushy? Healthcare reparations, they push for unifying creative and anti-oppressive approaches to a new world where community care elicits health. This is directly coming from an abolitionist framework. How are we abolitionists in the world of healthcare? How do we envision a liberatory world, start there, and then make it happen? Healthcare reparations start from a place of liberation for the most under-resourced and oppressed communities, and then strive to bring that world to reality in a way that does not hurt communities already experiencing pain at the hand of inequitable systems. The work of healthcare reparations is based on evidence-informed approaches, but it acknowledges many of those approaches are rooted in white supremacy and oppressive histories. Therefore, we have to use critical and holistic approaches to research. Healthcare reparations also weave future by incorporating Black feminist roots and intersectional frameworks, like I mentioned. Also, the trauma-informed practices, also grounding in harm reduction. Critical race theory and anti-oppressive and liberatory pedagogies. The other thing that's really important is that doing the work of healthcare reparation, it welcomes ongoing critique and feedback. We need to be accountable, and we need to remain honest and aligned with an anti-oppressive framework. So this work, it denounces racism, colorism, ableism, homophobia, transphobia, sexism, ageism, and all forms of hate, because those don't exist in a vision of liberation. And I would like to also note that it doesn't not only denounce them, but it actively denounces them, that this is an ongoing process. So what does that mean in terms of how we do our work with research? So there are some recommendations. So researchers, they make decisions, and those decisions have political consequences. When they decide who can speak, whom they can speak to, and what they can speak about. They ask what questions are asked, how we observe the behaviors, and also how we measure such behaviors. The theories employed and the manners in which they're deployed, and the method and methodological approaches utilized. It's like a picture, they all tell a story. That's a lot of power. Like, that's so much power. So how do we do it in a way that doesn't hurt people? So recommendations for research from a healthcare reparations approach. Let's consider the story the research will tell and ask if the story is rooted in an anti-oppressive framework. Avoid identity erasure at all costs. The pursuit of clean data should not void human existence. Actively name the oppressions that influence health outcomes, and don't conflate the burden of disease solely on the victim. Employ an intersectional framework into study designs that only enriches the story that's told. Give written acknowledgement to the climates, history, and subtexts that the study populations exist in as potential influencers to the data outcomes. Don't skip over people's stories. And this is something within my vaccine approaches that I've designed. It's called contextually informed consent. 6, seek to uplift the most silenced voices as a political act that can change the landscape for all. And 7, the last recommendation for research is being an ongoing accountability process. So as public health practitioners, we are in this feedback loop of research, but then we also feed that back into responses. So there are recommendations for how we respond. The first is addressing emerging and existing disparities immediately with both investment and action. Implement trauma-informed and culturally humbled practices into the veins of all responses. Do not cause more harm to already hurting communities and addressing inequities. The third is invest in teams who represent communities disproportionately impacted by negative health outcomes and pay them well. I will say that louder, pay them well. Do not cut out the impacted populations from their own paths to change. The fourth is institute national data systems that are rooted in anti-oppressive practices and intersectionality. Gather data that tells the fullest picture. Don't erase under-resourced populations. Fifth, follow through on promises and public statements. Don't tokenize BIPOC and under-resourced communities into a soundbite. Second to last, number 6, coordinate city, county, and state responses and systems into a cohesive unit that works for all people. Do not perpetuate systemic barriers. This is something that I would like to highlight for Minnesota, because we have a city, county, state system that is really complicated. It is so complicated. and it makes it really hard for folks to get services. 7th, acknowledge and name racism, the influence it plays on health outcomes, and include the historical healthcare harms that have been committed on the backs of marginalized communities. Don't ignore the root issues. So with all of these recommendations, let's find some synergy and let's see how this can show up in your work. I want to hear about the collaborations that you're working on. I want to hear about projects where you're like, I would love to incorporate an anti-oppressive approach into the work that I'm doing, but I don't know where to start. Or I just like want to say like, this sounds cool or not cool, or like, you're full of awesomeness, or like, I have so many more questions. I want us to actually find some time and use this time to go forward, because I hate in conferences when you then just have this presentation and go on your merry way, because we have the ability to make some change. So I'm going to stop sharing my screen. And before we start discussion, I'm going to just reground us, because we went all over. We did some reflection, we did some theories, I spouted a whole bunch of recommendations at you, but I want to step into a space where we can have a little bit of trust and honesty and be able to have some really good conversation in the 10-11 minutes that we have. So wherever you are, I just invite you to wiggle around a little bit if that is possible for you. Do whatever you need to do to kind of move your body. If that doesn't feel good to you, that's totally fine. Just take a sec to do whatever you need to do to just feel whatever you need to feel. All right. So I also invite, if folks want to, they can unmute their cameras. They can show themselves. You don't have to, whatever feels good. And let's just have a conversation. So are there projects that people are working on currently? Oh yeah, it's not 45, it's 40. That, thank you, Ellen, for that reminder. That people want to like throw out into the mix, or any questions or reflections?
Well, maybe I'm jumping right into a real big question. This is Annie, by the way. I'm with Twin Cities Medical Society, but I am just curious. I feel like as someone who works in public health, but has also kind of dabbled in other fields, I see that our field often falls back on things like, well, that's not evidence-based, or that's too political, or there are a lot of excuses I see that are embedded in our field that make us fall back into systems of oppression. And I'm just curious, kind of, what is the work we can be doing within our own discipline to move away from those excuses that keep us grounded in oppression and racism? It's a big question.
It is, and I will give you my 30-second answer. What are those excuses? Because they are excuses rooted in. Name what those excuses are rooted in and see where you go from there. So when people rely on evidence-based approaches, I'm not saying there's necessarily anything wrong with an evidence-based approach, but that being the be-all and end-all is rooted in white supremacy. There are so many other forms of research that we have completely erased. We've erased Indigenous research methods. We've erased non-white research methods. We've erased, there are scientists that have existed and been doing this work before America was colonized. And they didn't necessarily use what we would consider an evidence-based approach. Was their approach worthless? No. And so these are the questions that I invite us to have conversations about. Because when we actually get down to these root issues, we're just continuing to perpetuate them. white supremacy culture, which is really, really dangerous and is never going to let us get to a place of liberation. Okay, I could go on, but I'm not going to because we have 3 minutes. What else is coming up for folks?
I would say the question that I put in the chat box, well, it was a question / comment. If you have any more feedback on that, but it kind of goes hand in hand with people making excuses for not wanting change or changing their behavior. Yeah, that impacts community members meeting with healthcare staff. Mm-hmm.
Yeah, when you say healthcare staff, I think keep going, say a little bit more because
Yeah, so of course there are big barriers to accessing overall healthcare, such as financial disadvantages. However, I have more so recently, especially with the increase of just focusing on racial injustice, is people realizing they don't want to go to the doctors because they've had some pretty bad experiences behind closed doors, whether it's working with a midwife that's not listening to their concerns or a doctor that doesn't take them seriously. Yes, sorry, I don't want to take up too much time, so I'm trying to shorten it up.
No, it's all good because yes, I think we're about to get like pulled away from this room. And I don't know if I can answer that in 20 seconds. Sorry. But yes, what you brought up is 100% valid. And I'll just say that.
Okay. Yeah.
Yeah.
We are going to be pulled back very soon, but it seems like a lot of people want to talk.
Yes. Thank you. Thank you so much for sharing.
For a very good reason. Is there a way that you would prefer people to connect or follow up with you, Hadija?
Yeah, if you go to healthcarereparations.com, you can find my contact information there.